had introduced in Basak's presentation. So Christina, I'll go over to you to explain more. Thank you.
Yeah, I will do that. I'll just have to present. Yeah. There we go. So this is our study. So we're piloting a digital healthcare respiratory monitoring intervention to reduce drug-related deaths, otherwise known as the RESCUE project. So these are our disclosures. So I'm not going to go too much on the background because it has been said already, but Scotland has the highest drug-related death rate out of any EU country and 3.5 times of England and Wales. And most drug-related deaths are caused by opioid-induced respiratory depression because it sedates the brainstem, which controls respiration. Basak spoke about this earlier. And in Dundee, Dundee has the highest age-standardized drug misuse death rate of all local authority areas. And as you can see from the chart that is from the Tayside Drug Death Review group published last year. So in 2021, 68% of drug-related deaths occurred when people were using drugs alone in their own home. And basically, when people use drugs alone, that means that there are no bystanders who would be able to administer naloxone should it be needed. So this is the pneumowave respimeter that Basak mentioned in her talk. So the equipment consists of a biosensor and a gateway device, which I will refer to as the hub. So the biosensor is attached to the chest. It would be handy if I had one with me, but I don't, unfortunately. So the biosensor is attached.
Christina, it looks as though your slides have frozen.
Oh,
sorry.
That is, where has it frozen on?
It's just still on the first slide.
I think.
Oh,
I think you're showing the slides, but not the full screen presentation.
Right. I don't know how to fix that.
Probably, I think when sharing, you should choose a different screen, probably.
Okay, I'll stop sharing and I'll, right.
Just have another go,
because I have two monitors. Okay. Can you see it now?
That's much better, indeed. Thank you.
Okay, fabulous. Okay, so yeah, it attaches the chest with an ECG sticker on the skin, and it measures how the chest rises and falls, and from that, it produces respiratory rate. So the sensor is connected to the gateway device via Bluetooth. The data is collected when the sensor is within range of the device, and the data is stored internally on an SD card within the hub. And then during the study, I uploaded this through secure data onto a cloud server. And that was de-identified data. So pneumowave, they did not have access to personal information of the participants. Okay, so about our study. So it is a mixed methods observational cohort study, and it commenced in January 2022. So the aim of the quantitative study was to assess if this accelerometer sensor attached to the chest, if it can accurately and reliably capture respiratory patterns of people who use drugs. And the qualitative study assessed if this device is acceptable to people who use drugs and the stakeholders who would be involved in disseminating the intervention. So this is the quantitative study. So in the study, 70 participants wore a respiratory monitoring device on their chest for 4 weeks. So during the study, participants were asked to keep a diary of their substance use. So they would write what drugs they have taken and when, and the quantity. And participants would come to the Needle Exchange weekly for us to download the data and for us to collect their drug diaries and consent them. So participants were recruited on a rolling basis from an injection equipment provision service in Dundee City Centre, and the recruitment was carried out by research nurses who had a relationship with them. So this is the age and gender distribution. So as the majority of participants were male, and the main age category was 35 to 44 years old, which is important as that is the population that is most at risk from drug overdose. And majority of participants were living in their own home or were living in temporary accommodation. So most participants did not have declared medical issues, but the medical issues that were declared were mostly respiratory conditions. Yeah, so 70 participants had either completed or partially completed the study protocol. So 37 participants completed the full 4 weeks. 26 participants partially completed it, but were lost to follow-up, and 7 participants withdrew. And the data were reviewed after running prototype apnea detection and movement artifact algorithms that are not yet clinically validated. I will get to that. So these are just 2 examples of our data. So on the left, you can see data without apnea, and on the right, data with apnea. So that's over 35 seconds. And so the apnea algorithm, it processes raw accelerometer data and detects apneas. Well, the medical definition of an apneic episode is over 10 seconds of not breathing. So as it's an accelerometer, it has 3 axes, X, Y, and Z. So the highest level of probability are apneic episodes that were detected on all 3 axes. So focusing on the highest probability of apnea detection only, there were 8,614 episodes of apneic episodes over 10 seconds in 6,202.08 hours of data. So that was 22% of the detected apneic episodes. So the data were manually reviewed where the clusters of apnea were noted. So most of it appears to be consistent with sleep disordered breathing. Data analysis is ongoing, but the most common pattern is 10 to 15 seconds of apnea followed by 2 to 4 breaths lasting several hours. So right now, the point at data analysis where we are is to find false positives in existing data. So I'll move on to the qualitative study. So we interviewed participants who had completed the study protocol, which were 20 participants, about their experiences wearing the device in order to determine how it could be incorporated into an intervention pathway. And we also carried out 8 focus groups with members of the Scottish Ambulance Service, harm reduction workers, the Dundee non-fatal overdose group, the nurses involved in running the trial, and some staff and some members of support group. So for the qualitative analysis, we used reflexive thematic analysis to analyze interview transcripts. So preliminary coding and proposed themes have been reviewed by Dr. Andrew Radley, who is the co-investigator, and Mr. Brian Stevens, who is one of the research nurses and an outreach specialist on the rescue study. So the themes were interpreted through the COM-B model and NPT, normalization process theory. So these were the themes that were generated by the participant and stakeholder focus group interview transcripts. So for participants, it was identity and experience of substance use, intervention receptiveness and incentivization, emergency response and responsibility. And for stakeholders, it was barriers between people who use drugs and services, intervention integration into existing services, and the emergency response pathway. So these are the themes mapped onto the COM-B model. So for capability, it was the ability to actually attach the device to the body, and the ability to rotate sites, and then psychological, cognitive faculties, executive function, mental health. For motivation, the main thing that we saw that inspired people to get involved into the trial were experience with overdose and drug-related deaths, and the opportunity. The most important was a relationship with a therapeutic relationship with staff, housing security, access to services, and relationships. And for NPT, so the intervention was understood by focus group participants. They spoke about comparable interventions, and they also spoke about the importance of immediacy. And they identified that a death of a friend or a family member, that was a motivating factor for participation. But they also stated that this is not a cure-all. This will not serve all participants, that some patients, they may not be ready for an intervention of this type. And in terms of collective action, obviously, incentivization, if somebody does not have the means to plug this in and participate in this intervention in this way, then they need to be supported to do so. There was an issue of responder consent and mental health. If we're asking friends and family members to act as responders, then there needs to be a provision of support in that sense. And as was said before, by if this will use the Scottish Ambulance Service, it needs to be very reliable. So the main outcome identified would be lowering overdose fatalities, but a secondary outcome was the improvement of engagement with substance use services and engaging patients in their own healthcare. And I see Katrina is popping up to remind me, but only 2 slides left. So these are our future aims. So the data suggests that the device successfully captures respiratory anomalies. Quantitative data analysis is ongoing. I'm currently interviewing participants who did not finish the study. So yeah, I said that before, experiences with overdose or drug-related death, that was identified as motivating factor, but first responder groups stress the importance of patient choice and device accuracy. And a future aim is to refine trigger points for an emergency call response. So that is me. Thank you. Right,
Thank
I
you.
need to.
Thank you, Christina.
Okay.
That was great. And yeah, sorry if you felt a bit rushed. Lots of good information.
All right.
And again, just what came across, as well as the false positives from a tech perspective, the importance of the relationships with you know, a kind of service at a service level as well. So yeah, opening things up for questions for both Basak and for Christina. So if anybody wants to put their hand up and ask a question, or of course you can use the chat function as well. But we certainly have got at least 5 minutes for some questions if anybody wants to. David, over to you.
Oh, sorry, I'm being shy today, but it's all really interesting. That's why I'm being shy. So, I did put it in the chat, but I didn't quite hear it in the presentations, I don't think. Sorry if I missed it. You worked out how to discern between an intended respiratory depression and a life-ending respiratory depression, because often people take heroin because it slows them down.
Yeah.
And it just those tolerances between, certainly for sort of wearable or autonomous tech, I think are really challenging. So just be interested in anything that you've achieved or know around that.
So for
sorry, go on.
I just want to say, so for the rescue study, everyone who was on the study is still alive. There was no fatal or non-fatal overdose recorded on the trial. So that's that from my side. Bashak, sorry,
No, that's fine. I was just going to say, from the laboratory work, it's I mean, this is actually the crucial question,
Yeah.
to be honest. It's like I think this is something that we're still trying to grapple with. in the like the hospital studies, there was no one who was in a life-threatening situation. There was no interventions, even there was no one who was visibly impaired. But I can't speak that, you know, this was a small sample, so and these were people that had, you know, high tolerance and were on diamorphine for a long time, and I don't know how much of that has an impact, but you know, so we have questioned, like, are we just, what we're seeing physiologically is just a use event?
Yeah.
You know, it could be, or are people just teetering close to the edge? You know, how frequent do those apneas need to occur? How long do they need to occur for? We don't have those answers yet. So
it's fine. I just, well, that's the crux of it, isn't it? Really, that 56 or 59 seconds was. I'm sure there's a point where someone needs an intervention if it's like 5 minutes or something like that. But be interesting to see your work develop. Thank you.
Thank you.
Thanks for your question, David. And we've got John Dillon. I don't know, John, if you're going to answer a question or ask a question, but
I was going to add to that debate, because I think David and Basak have put their finger on the trigger. We've identified that, you know, the apneic episodes, which we thought were going to be the harbingers of an arrest and an overdose situation, actually occur very, very frequently, and therefore they're not useful. Whether those are what happens, or there is a special set of respiratory changes that presage an overdose, we haven't worked out yet. But it's possible that those levels of hypoxia that Basak was showing, induced by those episodes of apnea, are enough then to trigger a cardiac event that causes the whole cascade to unravel. So there may not be anything else different. This is the signal that we've got, and then it's very difficult to choose the sweet spot at which these devices activate and call for help, and that's the challenge we have at the moment. There is some work going on with colleagues in Australia in on-site injection facilities, where we're using this device to try and see if there is a difference where they do have naloxone requiring events on a regular occasion. So we will get that data over the coming months, hopefully, to start to answer some questions and get some more of that data until Basak gets her diamorphine supply restored, and we start to see what happens in the lab as well.
That's really helpful, thank you. But I think it will make all the difference, isn't it? The last thing clients are going to want is a smack bang in the middle of something they want to experience, and automated naloxone injected into them. But it's early days. We've not looked at this in great detail before, have we? So it's finding the right questions to ask to get us to the solution.
That's exactly right. Thank you, David, for your question. So we'll take one more question from James Nichols, and then we'll move on to our final speaker. James.
Yeah, that might be picked up by David's last point, actually. I was going to just follow on from what David was saying and just ask, has this come up in the qualitative research at all? I mean, is this something that people using the devices are concerned about? Because I would imagine that one of the biggest risks to uptake would be if word got around that they trigger at a very low threshold, then it could, you know, the whole system could be, you know, the levels of acceptability could be very low. So I'm just wondering if that's come up from the qualitative research, and if not, how that might be tested.
I can very briefly talk about our acceptability work. I didn't get to talk about, but I think accuracy was probably the biggest, most common theme that came up in the interviews that we had. So we gave people a variety of different devices to hold and to play with, but they didn't take it away to use. But through in our kind of discussions with people, so accuracy about whether the device can detect an overdose, but also trusting that accuracy was a huge factor as well. So people want to kind of protect their high, but you know, they want to protect their lives but not protect their high, and that is very understandable. So it is it definitely came up as a huge theme.
Thank you.
Thank you. So that's great. So thank you so much to Basak and Christina for introducing and started to talk about the physiology and the response and that qualitative work that goes alongside that. So it's very much an area for development, isn't it, that we're still learning, as we see. So now I'm going to move on just to our final speaker, which is a little bit different in that it's not a presentation on technology as such. It's more about our networking opportunities around this. So I'm delighted to introduce John Shorrock. John, formerly of Bristol Drugs Project, but now working in the Department of Health as a programme manager in the Drug and Alcohol team. So John's going to tell us, well, I'll let you explain, John. I'm going to just hand over to you.
Thanks very much, Katrina. It's all right, I'm just trying to find my presentation now. Bear with me. I don't know why it's disappeared. I think it's because we've gone live. Bear with me. I'm going to try. If I can't get it up, I can kind of, in a sense, do it without, which would be a shame because of the work that.
We can share it from our end.
Yeah.
Can you share?
Yeah, absolutely.
Yeah, that'd be great if you could. That'd be really helpful. Thanks very much. Okay, hi everybody. First of all, thank you very much, Katrina, for the introduction. I just need to make something very clear from the outset. So, although yes, some of you may know me from my OHID role, working with the Addiction and Inclusion Directorate, I'm here today in an independent role as a research collaborator, which is a role that I do in my own time. I make no financial benefit from. But yeah, just be really clear. So I just want to introduce ItSpoon. But before I do, just talk a little bit about my kind of own journey towards this. So yeah, me and a colleague about 4 years ago, really connecting with not only overdoses, but actually more and more increasingly about the fact that people are dying alone. And that actually, as much as naloxone is a really positive intervention, if there's no one there to administer, then actually it's rendered fairly useless. So we were kind of thinking about in the technology space. I think lots of people were thinking about it, which we weren't aware of. And then we slowly but surely started to put together a research collaboration, which involves some of the people on this call. And at the moment, we're waiting the outcome of an MRC application around an early responder wearable device oximeter. So anyway, but through that time, I've connected with some of the people that have been presenting today, and then going back to a conference, an SSA conference last year. Many of us, were in the same room, and it just struck me at some point, actually, we don't have a network in this space. Anyway, we all agreed that actually it would be really beneficial. I put my hand up to convene the group, and in fact I'm a convener, I'm not a chair, and we've gone for a convener because I think we want it to be less formal than necessarily a chair. So I have put my hand up. We've met a few times, but before I do, just a little bit more about who we are and why we exist. So if you go to the next slide, please. So essentially we are a network of researchers, scientists and service providers, and we've all been kind of working independently around this work. There's been some connectivity, but we've never sort of come together and shared those ideas. But we're all working towards the same aim of preventing largely opiate overdoses and looking at technological solutions to be able to. You've heard a lot today around what people are doing. It is fairly embryonic. There are some real positive signs, and there's so much space for technology in this area. There's much more reasons to be collaborating than competing, given particularly what we're all trying to achieve. Next one, please. So I'm not going to go through these one by one, but I think you can probably guess, really it is largely about coming together, sharing ideas, sharing data. There's certainly some data in our own application. If I'd have known and been able to access from some of the other people now in the network, we probably would have moved our application on quite considerably. But we really want to try and make a device that is all inclusive. There are really big and not necessarily got picked up a lot today, but genetic, race and societal and nation differences, and we really need there's no one size fits all approach here. We need a lot of different things, either working together in conjunction or with other things. And some of the things is that we've really got picked up today is that human interface stuff. There's a whole raft of issues around safeguarding. There's a whole raft of issues around psychological support, post-event, etc., that we really need to give some strong thinking to. Next slide, please. So the network, as I say, I mean, as much as the work is in some ways embryonic, the meeting's even more embryonic. I think we've met 3 times now. It is very much by invitation. We are quite a small group. I think there's probably on the last call, there were about 6 or 7 of us. We approximately bi-monthly, and the next meeting is the end of April. It's been, to date, it's all been via Teams. We'd love to have a face-to-face meeting. The more international that is, the better. And on that note, we are looking at how we might fund the group, and some ideas and options have been put forward, but as yet we're completely unfunded, but we hope to be at some point in the future. And moving on to what is the last slide. So so we do have now, and a massive thanks to Hadi Danashah around this. He's done the work around this. It's hosted by Stirling University. So we've got a website. I think Hadi is going to, there he goes. Look at the timing. Hadi's going to put the link in the chat, so you can go and jump onto that and have a look. That's my contact details there as the convener. So if you are interested in joining us, please do drop me a line. I'll try and respond as quickly as I can. But yeah, you know, we're new, we're here. I think, you know, again, if you are developing devices, it might be a network that's of benefit to you. I think, Katrina, that's me done, unless there are any questions. So if you want to stop sharing, that would be really helpful.
That's great. John, thank you so much for introducing ITSPOON. And yes, what we have time for now is any questions, and it's questions for John about the network, which, as you say, is just very much an early initiative. And also, I guess we have time still, but kind of 10 minutes left in our allotted time. If anyone wants to raise any questions they didn't get a chance to earlier, or just to make a point or share some further information if they're aware of other developments in the area, this is your opportunity. So please do jump in, put your hand up, or make use of the chat if you would like to. So we've got Wayne.
Hi, it's just a general question. We all know that people with alcohol and drug difficulties are less likely to be able to access general primary and secondary care for other health conditions beyond their alcohol and drug issues. And that includes things like sleep clinics. So sleep apnea is a very common condition across the UK. It's highly underdiagnosed, and I would argue that it's probably the case that drug users are less likely to be diagnosed with sleep apnea than those who don't use drugs. I wonder if there's a connection between undiagnosed sleep apnea and the kind of danger thresholds, if that's the right terminology, for folk who are using opiate type drugs.
Thanks for that question, Wayne. I'm going to ask Basak if she wants to. I'm making a judgment on who might be the best person to answer the question. So Basak, that's you.
Yeah, that's a great question. I don't know. I think that there's a lot of overlap with the respiratory physiology that we see in our experimental work. There's like, I don't know if you can remember the traces that I was showing with the airflow. So there was like this, it's quite a distinct waxing and waning pattern. So like people are kind of gasping a breath, and then the volume of the breath actually decreases, and then the pause happens again, and then it just keeps repeating. And that's kind of what you see, I think, in sleep apnea, mainly in central sleep apnea, and from what I can understand. But there's some things in the literature about this being there's a distinct kind of opioid induced respiratory pattern, or opioid-induced apnea. So in terms of how much it really overlaps with distinctively with sleep apnea, I'm really not sure, but that's definitely something that has come up a lot. And then from just knowing that the symptoms of an overdose, snoring, for example, that there's so much overlap in that, that it is a really crucial thing to examine further. I would love to do a sleep study, but we've had plans to do so, but we haven't managed to do it yet. But that would be great to do that.
Thank you, Basak. And we'll go to David.
How are we going, everyone? I wondered, these things, with all things, the more data points you've got, the easier it is to discern the condition. And it might get to a point where sleep apnea or respiratory depression isn't enough in of itself. So are we considering any other physiological data points that might indicate overdose emergency?
Yes is the answer to that. There's a number. There's pulse oximetry measuring blood oxygen. There's movement sensors in terms of chest movement. There's also breathing sensors that measure movement in the ear just from somebody's breathing. There's electro connectivity around electrodermal measurements as well, because there's changes in the skin around overdose features. There's a whole range of different physiological measures that are, and it's getting that combination of which are the best, or which are the most indicative, or is there a pattern of physiological signs that is the best indicator of when an overdose is happening or is more likely to become a fatal overdose. That's my tuppence worth in an answer, but I'm sure there's probably, Basak, you may also have some thoughts on that, or anybody else that might want to come in. Maybe John Dillon might have some thoughts on that as well.
If anyone else wants to jump in, I'm happy to add something as well.
Yep, please, you go ahead and add something.
I know, I was going to say that's similar to what I wanted to say. There are many different parameters that can be looked at. In terms of, so what I kind of was highlighting in my talk was that it's difficult to know at this stage which one is the most accurate and reliable, but what we are seeing is that the measure of the pauses is probably the most indicative of an overdose situation, but there are many indirect measures as well, and also it could be something like just a lack of movement, for example, that might also be a good indicator. That's something that just needs more testing. And then also just, is it just one criteria? Can you have multiple criteria that are synced to each other? Or that this is all being tested at the moment, I think so.
I feel that's going to be the end solution. Multiple criteria equate to. I don't think any one, by the sound of it, is going to be enough in of itself. I'm no medical research, by the way, but that's how it sounds.
Thanks, David. John, have you got anything that you want to add?
Were you talking John Dillon or John Sherratt?
Well, I was thinking John Dillon, sorry, because his camera's come on. but yeah.
I'll start and John can follow.
Exactly, thank you.
I think, David, there's also the issue of practicality, because we want these devices to be instantly and easily available, and ideally people that can carry them around with them all the time. So the respiratory monitor clearly ticks that box. Whether we need anything that measures end-tidal gases is hugely complicated, so isn't going to be very practical. So you're then looking at sort of cardiac parameters, which may come too late. But if we don't find a particular pattern of breathing that predicts the need to intervention and find that sweet spot where and differentiates between a high, we may need a cardiac monitor, etc., which would be then a smart wristwatch or a smart ring, etc., and having backup if we're trying to get the point where people are relying on these devices as safe virtual injecting environments, then we need to have backup. So if the monitor comes off the chest, you've still got some other measure of what's going on. So those are the other issues to think about when trying to come up with the ideal. Don't know if John wants to add more.
Thank you, Doctor.
I think you're absolutely right, David. I think I was saying in the presentation how much space there is for solutions here. I think, you know, if we take different environments, you know, hostels is a classic. You got a captive audience, you could put motion sensors in most of the rooms there. For other people, you know, even wearable devices which are wrist. Some people's first thing they've said through acceptability of use, I injected my wrist, first thing that's going to come off, going to be very, you know, is going to be useful. So, you know, again, you know, for a lot of people that might work. For other people, it's going to have to be mounted some other way. Then can you get the same level of detection? And then we've got all the anomalies around, melanoma in the skin. So we're going to have to, you know, there's going to have to be lots of different solutions to delivering this. It's not going to be one solution in my mind.
Exciting, I think.
Yes, thank you. Thanks for your question, David. So I just wanted to give Gillian an opportunity to come in. There was a couple of questions in the chat around the Here For You app that maybe weren't. And so Gillian, if you are still there, yes, you are, great. Just to finish off, if you've got, if you can maybe just address some of those questions in the chat, that'd be really helpful.
Let me just kind of scroll back. Opened up the chat just now. Let me have a look. How many workers over the week are actively to maintain that? It is a challenge. It is a challenge to get supporters. I must admit that took a bit of time. Try to develop that, and volunteers. I kind of looked at only putting the app on live initially for a short time. And what we looked at was, and Katrina will back this up with the recent kind of stats from the SAS reports, looking at when are the kind of high risk times that people are overdosing, when, and I know that can be very variable, and it's middle to the late afternoon, maybe thinking about people in the morning using substances, maybe topping up with benzodiazepines and then maybe injecting heroin in the afternoon or whatever their substance of choice is. And maybe that polydrug use, you know, can play a part in this, but there's many factors. It could be tolerance, it could be naive users, the substance was pure. So it's tricky. So we chose to use 11 o'clock AM till 5 PM and do 2 shift patterns. So 11 till 2 and 2 till 5. It's quite manageable. With people working from home now, I had lots of buy-in from people who are working from home, who are working throughout the ADP, the drugs partnership up here. They checked with their bosses and they were happy to play a part for Aberdeen, test this pilot. So it's getting that buy-in sometimes from your kind of local ADP partnership who can share that to try and get much more people. Currently, we've got 1 person on duty at any one time. I know I'm a manager here, but I've always got my phone on. I just every day at the moment, while it's quite new, I just always put my app on, and I've got a couple of staff here that equally do, so we've got the backup. But currently, while we've only got a few people with the app, and someone else asked me how many people have got the app currently, we've only been going for about 11 days, and we've got 5 people now who have actually got the app. And you guys will know yourselves, trying to get people in the house sometimes, because it's not, they don't do it on their own. We sit down with people, we make sure they're understanding about it. We put the app on the phone, and we often supply the phone, because that can be really tricky, again, having a smartphone to be able to download it. Someone else asked me a question, I see just in the chat, about who do we call when there's an emergency. On the individual's app on their phone, that's where anything is stored. The supporter, nobody accesses that information because it is anonymous and we don't store data or anything. So that individual, when we're setting them up with the app on their phone, only takes about 5-10 minutes. There's a rescue plan you create, a bit like a next of kin, someone close by, that like a neighbour or a friend that might have naloxone, that maybe can come quickly to you if you're starting to feel unwell. And I kind of make the link, a bit like my gran used to have a community alarm, where she had a bit of a pull cord or a thing around her neck, and there was a 2 or 3 of the family, they would call if she had a fall before they initiated the next in line, where it might be emergency services. So we would, on that telephone call, if we had some concerns and the person was still speaking, they weren't unconscious and unresponsive, and we would say to them, can we have access to make sure we call one of your plans, your rescue plans, and then they press and they share that information, and then I see it. And then if we don't, obviously, if we're concerned that there's been silence on the phone, there's maybe been the phone's dropped, we hear a thud to the floor, maybe some snoring that somebody's quickly went into, you know, an overdose after 5 or 10 minutes, or it could be initially, there's an instant, you know, quick silence. And that is a challenge, and that's why I asked my client, and when I spoke to the other day on the phone, saying, what would be normal for you? You know, because she was happy to share what would be normal. Should I expect you to be quiet? Should I hear a change in your tone? Will you drift in and out of sleep for a few minutes? And again, as we go and as we learn, we start to build more of the supporter conversation in that I have created on Teams that everyone can access when they're on duty. So, and then if we don't call a rescue plan, if we are concerned that there is signs someone has overdosed, we've got a function on there that says get help, and that's when we it goes straight through to a 999 call to the ambulance service. Any more?
That's probably all we've got time for.
Okay.
But please do type anything else into the chat. And yeah, I think it's just time to wrap things up. Thank you so much for sharing that additional bit of detail. So yeah, I'm just going to wrap things up now. It's 5 o'clock, and I'm sure you're all thinking about the evening ahead. There's been some good links in the chat, and I do want to give a shout out to Simon Community, who developed an app. So and I think that's in there in the chat function. People can have a look at that as well. So there's lots. I think the message is there's lots happening, and we would be very keen to try and share learning for that. The interface between the kind of academic piece, the service delivery piece, and of course, obviously, the technology itself is very crucial. We really want to share that through the network that John has introduced today. So please link in if you can, if you're interested through that. It's very much open. So I'm just going to thank everyone again, and thank you to everyone that's answered questions, everyone who's asked questions. It's been a really good level of discussion. And finally, I just want to thank Jess from Drugs Research Network and Hadi Danishvar as well, because Hadi was instrumental in bringing the group together for the presentations, and Jess does all the hard work behind the scenes to make sure things move smoothly. So thank you very much to you guys too. And I'm just going to say have a lovely evening, everybody, and let's keep in touch and share our developments as they progress. So thanks, everybody. Good to see you.
See you all. Good evening.
Thank you.
Thanks,
Bye.
Katrina.
Thank you.
Bye.
Thank you.
Bye.
Thank you.
Thanks, Katrina. Bye. And thanks, Katrina, for chairing.